The next session that we're running today is, I think, going to be very exciting for all of you. It's giving us a chance to really go in depth and explore some of the things that we've heard about this morning through Mark's presentation and through the work that the policy fellows were telling us that they had done last year. And what we know is the ACN's view in terms of where they see their work evolving over the next 12 months or so. So it's a really useful session. You've got the expertise of some amazing people here to hear from, and we're going to encourage a dialogue between the panellists and then between yourselves as we go through this morning. We've got an hour and 15 minutes, or an hour and a half actually. Now, the panellists have been introduced to you when David spoke earlier this morning, but I'm just going to, so that you've got the names and the faces, point them out to you. In no particular order: Karen Booth, Dr. Stephen Duckett, Karrie Long, Sabina Knight and Mark Cormack. And I'm Karen Cook, but you know that. What I've asked the panellists to do, because they each have a different lens that they look at the nursing workforce through, so I've asked them each to do a 5-minute trigger presentation, and then after that we're going to have a conversation between the panellists, and then we're going to open the floor to questions, and there will be roving mics. So get your questions ready for that part of the session. And currently we're looking at 15 minutes, but we might do a little bit longer than that, because I think that the conversation is going to generate a lot of questions for you. All right, so without further ado, I'm going to start with Karen Booth, and Karen's going to give us her 5-minute trigger presentation.
So my theme is excitement, because I think this is a really exciting time for health and a really exciting time for nursing. We've had, I've done decades, have we done decades of health reform? And I think we're actually starting to see real things happen, which I think is a wonderful thing. We've had the scope of practice review that Mark talked about this morning, with really strong recommendations for change, to look at better ways of working. We all work hard, but we need to work smarter and better ways of working. Too often we hear the squeaky wheels talking about their work, their turf, the problems with change. But I think we're, as a whole, across most of the discipline groups, agree that actually now's the time for change. We have, funding for primary health care and chronic disease management. The current system's not working, so we actually need to look at how we remodel that. And we absolutely need to change, and we need to actually have a greater focus on multidisciplinary care. Catherine Zeitz and I were up the road at Parliament House this morning for the press conference, telling the press exactly that: what nurses want, what nurses need, and why we need to change. I think another exciting thing that's happening is that the nursing standards are under review. So I know lots of you here will be contributing to the enrolled nurse standards, the registered nurse standards. And I think now's a really good time to actually be future focused. Where we're going, what are we going to do, not just now, but what are we going to do in the next decade? Where are we looking in the next 2 decades? So we need to really look at what do we need in that workforce. We've got increased knowledge across our nurses, increased capabilities, and of course increasing community needs and increasing community demands. And we actually need nursing standards that reflect that. So we're not handmaidens anymore. They're not servants. We don't need hands-on supervision for everything. So I think we really need to look at where we're going with this. And the other really exciting thing that's happening, and particularly in my new role with the Digital Health Agency, is this digital dawn. We're all using technology, but then going to the next step. I just spent 2 days at the IT in Aged Care conference, and they're talking about robotics and, robotics in care and what countries are using that already. And we're looking at AI to assist in record keeping. So we really need to make sure that we have nurses and a health workforce that know how to do that stuff, that understand the safety issues around that, that understand the ethics around that. So we actually need to build that in. There's lots of, there's very positive talk, the agency, everything's an uplift or an upgrade. my Alexa will be able to tell you. And so we're seeing the sort of the platform that things like My Health Record is on at the moment is moving to a dynamic new level where it's actually going to be quite interactive. So all of those e-scripts, all of the My Health Record, e-referrals are all going to come through this amazing sort of like information superhighway. And so we'll be much more connected. And once we're connected, any complaints about fragmentation of care will go, because everyone will be able to see, including the patient or the consumer, what everyone's doing. Exciting things happening in aged care. The digital technology in aged care is incredible. People going into homes, they've got an iPhone, they record patients' activities on an app that feeds back to base. So all of these really exciting things that we need to be aware of. And of course, there is the nursing digital capability framework as well that we should all be across, and then look at how we build that into what's coming for our standards, but also in the way we work.
Beautiful. Thank you, Karen. Stephen.
Thanks very much. So Mark, I think, presented to us, in a sense, what might be called the burning platform for change. That is, change is inevitable because there is no prospect that healthcare in the future will be able to be delivered in the same way as we're delivering it now. There just will not be the workforce. There just will not be the distribution of the workforce. So we are going to have to do things very, very differently. And that applies across a range of areas, not just primary care. However, I'm not a burning platform sort of person because I think once you put the fire out, then the energy for change goes. And so you might say, oh, we're going to fix this by 10,000 additional GP places or whatever it's going to be. I'm more interested in a burning ambition sort of argument than a burning platform argument. The burning ambition argument is this, that our population is growing older and sicker. Those two things are not the same. And so we are going to need a very different way of delivering care, which is the multidisciplinary care argument. Secondly, the context in which care is being delivered is changing. So we need to have a health workforce which is much more aware of the socioeconomic determinants of health or drivers of health, much more aware of, as one of your next year's fellows, the trauma-informed care and so on. And these are not necessarily skills that every health professional learns in their undergraduate or pre-professional training. If you put the word general practitioner and socioeconomic context or trauma-informed care, those are not words that sit well in the same sentence. In fact, the words that sit well in the same sentence are MBS item numbers and general practice. But so primary care in the future needs to look different, as does every other aspect of care. They are not different arguments. Mark put the argument about the importance of retention and the importance of top scope of practice, full scope of practice and all of that. So change is inevitable. What is then the issue is not change, because we all know that all the reports of the last couple of 100 years or decades have all said the same thing. So what is important is not what is being said, but rather doing something about it, and more importantly, managing the transition. There is a big fear of change because people are very comfortable. And so we've got to actually bring the stakeholders along and help the stakeholders manage this transition. Many stakeholders think, and especially the medical profession, that this is a zero-sum game, that if I give up something, I have lost. That is not actually the reality. It's not my view on these things. We've got to actually be thinking about managing the transition of funding. So, for example, the GP incentives review, of which I was a member, talked about the same sort of recommendation that Mark has made about, on average, changing the way that funds flow to general practice. So instead of 90% on average fee for service, 10% on average other funding, it would be 60-40. Instead of In my general practice, you have I've changed my general practice, I'd have to say, but in my old general practice, which was bought by a venture capitalist, which was one of the reasons I changed, we had 3 general practitioners and 1 nurse, to a multidisciplinary team practice. So we're going to have to, and the GP Incentives Review talked about changing that ratio from 3 to 1 to 1 to 1. So a very different on average. It is not, as some people claim, compulsory to have 1 to 1. That is not what is said. That's misinformation. The fact that we have misinformation in the policy space is not a surprise. But we do need to be clear about where we're going and managing that transition of funding, managing the transition of information, managing the transition of education, because I don't think every health professional is educated to work when we are moving from a very hierarchical system to a more team-based system, and your definition of team, their definition of team, my definition of team might all be very, very different. So I think there are 3 streams that we have to be thinking about. One is helping general medical practice adapt. Even though they may fight against it, we still have to help them adapt. We have to help them understand that just because there is no item number for a practice nurse to do this or X or Y, that we need to change the way in which practice nurses are used in the roles they have in general practice so that they can work to top scope of practice. The fact they don't now, in my view, is a failure of regulation, that basically the Commonwealth Department or the Commonwealth Government has just said, have this workforce incentive program. We hope that the nurse is going to do something other than cleaning out the cupboards, but we're not going to care. So some practices, unjustly in my view, are getting extra money for nothing. And that's a failure of regulation. And the second thing is we have to change the contribution of every other aspect of the system. It is not just about general medical practice. This has to happen in parallel. It's not an alternative. And thirdly, we have to think about what do we do locally. I have been working in the health system a long time. When I worked in the Victorian Health Department many, many years ago, if there was some problem I didn't want to deal with, I just couldn't cope with, there were 2 strategies I had. The first strategy was refer it to the Public Health Division for comment, and then it would just vanish into this black hole, and that was good. The other strategy was to say, this is a Commonwealth state issue, and it vanished into a black hole. So my point is this, we should be getting on and doing the job. You'll be surprised how few constraints there are to start change locally. You've heard already, things happen in the hospitals, things are not happening in general practice primary care, partly because of fear of change, partly because people are unaware what the constraints are and so on. So I'm an enthusiast about moving on multiple levels simultaneously. Thank you.
Brilliant, thank you. Karrie.
Great. I'm taking a slightly different tact, I suppose, to my 5 minutes of fame as a modern leader. I'm not quite sure what modern means, but let me see what I can do there. I saw the title of this session around optimising the role of nursing in health reform. And as a government chief nurse and midwifery officer, I wanted to take that, particularly today and the purpose for today, and see that in two spaces. Nurses as actors in the process of policy reform, and secondly, nursing as a profession as a recipient of the outcome of the policy reform. So as a government chief nurse and midwifery officer, this is absolutely my everyday component of my work is policy reform. It's seeding it, informing it, advising on it, consulting on it, developing it, implementing it, monitoring and evaluating it. And you will have seen that now with designated registered nurse prescribing, as well as the National Nursing Workforce Strategy. So really want to put to nursing and midwifery professions, there are active case studies that you can be involved with now to understand and educate yourself and expose yourself to policy development and have a say, and I think that's really important. And what I took away from that is probably 3 E's for us to consider. Exposure and experience. Increasing opportunities to be exposed to the process. Forums like this in advocacy, in professional or industrial bodies, be involved in consultations in the development, and in the National Nursing Workforce Strategy, we had over 6,000 touch points of consultation, which was significant. What we also did in that space, the Commonwealth of Victoria leading that, was publish as we went along the findings. So it's a bit like Hansel and Gretel, leaving crumbs along the way for people to look and understand. And I think that's a really important element of uncovering the architecture, which is, I think, one of the fellows talked about this morning. Education is important. I constantly come away perturbed or concerned that as a profession we're not highly articulate in understanding around how policy works and, can I say, how government works. So I think that's a really important takeaway, both in our undergraduate training, in our postgraduate training, in our leadership development. We need to understand that. And I think there's options that we can do that are broader than perhaps the opportunities for policy learnings at ACN, or I was involved in ICN's Policy Institute. In my office, I've taken the opportunity to second 2 senior leaders in to understand the insights of my role, so I can build capacity and capability going forward to have strong leaders, because goodness knows I've learnt a lot over the last 2 years. The other takeaway is evidence and evaluation. So how do we collect really strategic, important evidence around the problem? How do we present that strategically? And as both professions, we need to take a really good look around how we articulate that. And on the other side of presenting the case for change and the problem is looking at how we evaluate and monitor, did it work? We are using public funds to enable these policies. There's transparency. We need to understand, did they work, did they not? Failures are the greatest learning that we know of, and we really need to capture those. So just in summarising, I really looked at the 32 years of my career to think about what were the large policy pieces in my time that I've seen progress. So that transition from hospital to tertiary training. I was very much on the precipice, could have been in a hospital training, but went to tertiary. National registration. As a clinician living on a border town, which I did for 20 years, that was absolutely pivotal. Introduction of nurse practitioners, and as we've seen now, this is an evolution. So that the removal of collaborative agreements is, sometime afterwards, that continuum. So policy shouldn't stop, it should be evolved and evaluated and worked as a mechanism. And now we see designated RM prescribing. So for my takeaway, these are all about maximising the capability of nursing for the population health needs that we have. And very much, you will see in the National Nursing Workforce Strategy is a tenet of releasing the economic value of nurses for population health and a prosperous Australia. We saw that in COVID. We saw where there were industries that might have been wiped out, such as meatpacking industry, and I'm talking about my experience in Victoria. If you don't have a healthy population, you don't have transport, you don't have food, you don't have other things. Nurses and midwives in our reach are absolutely contingent on that. So in wrapping up, optimising the role of nursing in health is really around population health. The costs of that are held by the population. So that is a really difficult rationale to put up when we don't have societal economic evaluations to see what the cost is. So really challenge us to be strategic when we're thinking around developing policy. Thanks.
Your 5 minutes of fame is actually sitting next to me. Sabina.
Thank you. Well, my tonal temperature is optimistic. I was sitting here thinking it's not quite going back to revealing the mosaic paths of Ephesus in how nurses have influenced policy in Australia, but I did want to talk about, it has been a while, but you touched on it, Karrie, the things that we have been successful in that we don't actually celebrate and we haven't gone back to see why it was successful was, first of all, it's national registration. It was nurses that led that, and it was in remote area nurses that led that. It was a long campaign, but it got just its moment in time. You know, every now and again something comes together and you get that moment in time. And at RMAC, as it was then, and the Ministers' Council, it resonated, and rather than just do it for nursing, they went the whole hog, and it was unpopular, but it went through. And I think it's something to celebrate, but to remember, very small group of nurses spread across the country really drove that, and the college came on board and got behind it. So I think that's important to remember. The nurse practitioner trials, similarly, back in the 90s, sort of again built on the back of this is going to change access to care in remote areas. Had the trials and demonstrations, worked brilliantly well, didn't follow through with the financing and support for it. So we, on the very case study that we introduced NPs in Australia, is probably the one area that where we haven't been able to maximise their contribution because we didn't get those other things right, and for all of the things that you heard of this morning from Mark. And nurse prescribing. So again, in particularly protocolised prescribing, which has got to be most prescribers these days in Australia, including GPs, in that there's well-developed guidelines, best practice, evidence-based practice for the treatment of common or clinically significant conditions. You follow if you're a GP, you follow your RSEGP Red Book. You know, if you're a remote area nurse in the Queensland, you'll follow the Queensland Primary Care Manual. If you're in WA or NT, you'll follow CARPA, whatever. There are evidence-based guidelines which are well supported, and on the back of that has really provided the case for, there's really strong evidence for nurse prescribing in other areas. And so we don't forget that, and we need to keep reminding ourselves and our colleagues around we're all about providing best outcomes for patients and clients, and so this is not just a nursing thing, but it's something that we really value. So I think the pillars are in place for reform in that, as Karen said, we've got national registration, we've got the digital platforms emerging, most help in primary care land. Everybody's on a digital health record pretty well. There's very few paper records left because they don't get incentive payments if they don't, not digital. And in the remote services, they're all digital, whether they're state or community control services. So we've got good medical records, and we have the ability to have shared care there. And the uplift of that onto the national platform is coming, and it will improve, and it needs to improve, but it will improve, and so that's important. AI is going to radically change what we do. It not only in interpreting the tests and investigations that we will order in the future legitimately, but being able to support clinical decision making much better, timely prompts as you go. You can sit and talk and work with your patient. The AI programs, they will summarise your notes, read it back to you. You can confirm with the patient that you've got it right in real time, and you've saved a lot of time, and that's only going to improve as well. So those sorts of things will really change. I think what's not there is what we've heard. We don't have the financing models. We absolutely don't have a primary healthcare system. So as we heard, the hospital system's well developed, well funded. They get under the national payments, they get a large chunk of money to support teaching, training and research. That doesn't happen in primary care land. It's not because there's resistance, it just hasn't ever happened. And so there is some training payments for the supervision of medical students and registrars, but there isn't for any other discipline. There isn't payments for research, there isn't payments for team activity. So if you stop work seeing patients to do other things, you lose money. And the margins are pretty thin, so the current payments aren't there. So in the way we fund primary care, it's not just the financing of it, but the driving of the behaviour. So we do have the teaching, training and research as central to, as important to primary care as it is to acute care in the tertiary system. When we do that, we will see change. And so that will allow us to, at the same time, our big challenge, and you've heard me talk on this before, we have to have a radical change of nursing education, that we need to stream nursing education to primary care and acute care. There's absolutely no reason why we can't be having students placed in primary care right throughout their nursing education, and then they're ready to practice in primary care on graduation. If I move from orthopaedics to emergency, by golly, I'm going to have to do some upskilling to change. If I want to go from primary care to the hospital, I've got to do the same, or vice versa. So let's not pretend that we are producing graduates who can do a range of things, largely in the acute care sector. But we can turn that on its head. We need to produce a workforce for the acute care sector, for aged care community, but we absolutely have to produce a primary care sector. Let's give students the opportunity to stream. Let's embed them, as we currently do, in some of the rural clinical school programs where they've got long exposure. So they're learning the art of nursing in primary care as students and then as graduates. And then they can learn the finance and all the other stuff later on. Like, at the moment, we want people to be able to do it all at once when they go to work in that sector. And no wonder it's not so satisfying, because it's a lot to learn and not very... you don't get a lot of professional satisfaction when your scope has been constrained down so narrowly, unless you're working in very remote Australia. So those financing things are really important. So that career pipeline is really important. We need to invest in teaching, training where we want people to be. So that means more dispersed nursing programs, that nationally accredited, all the things we talk about. We need to build supervision capacity, use remote models of supervision. At the moment, our standards say you've got to be supervised by a nurse. If you're a nursing student on placement, I would challenge that. Got to be a nurse in the team, there's got to be people around. If we're going to do interprofessional work, we also need to accept that parts of our day or days can be supervised by others as we're growing. And I think we should challenge ourselves in these next reviews to make sure we do this. I currently work in a town where access to primary care is very tight, but if you can pay for it, you get good care. But people who can't pay for it get no care. And we, as advocates, we need to lead the change on this. So from a policy perspective in this forum, we need to be loud voices and effective voices for people's access to care. And if we had more nurses working in primary care who could and should be targeting care to those who currently do not have access, then we are going to improve outcomes for everyone. And so those block payments could do that. They could also take pressure off waiting lists where people say, I can't get access to urgent care in primary care where it should be because there's no appointments. Well, if you used your team better, that would change. So I remain optimistic as we work on the career pipeline, we have more dispersed programs, stream into primary care, and restructure those pillars to make sure that we've got a career pipeline. And I think challenge ourselves around how we educate our undergraduates and postgraduates, where we do it, we can make quite a difference. All of this takes time, but we could actually make a substantial difference in 5 years. And that's not a long horizon in healthcare.
Okay, thank you. Mark, we'd like to hear just one more comment from you, perhaps.
One more comment.
I know you've spoken at length 45 minutes to be precise.
That's right.
Or I can just throw to questions from
I
the panel.
think throw to questions. Yes.
Okay, so the question I wanted to start with, Mark, you talked about regulation and you talked about consumers, and you said the consumers don't care about the titles, but they want to know that behind the titles and behind the person delivering the care is a system that protects them.
That's right.
That makes sure that they're safe in the care of whatever the title is of that person is. Karen spoke about the fact that the standards are currently under review. And Karen also spoke about the impact of technology and that nurses will be using a lot more technology in the future. So I guess my question is, in terms of nursing and its place in the multidisciplinary team, what's the work that we need to do in terms of nursing standards, nursing education, to equip nurses to work in this bold new future where they're using more technology, they're working in multidisciplinary teams? How do we need to change those standards? Do we need to throw them up in the air and rejig them? Sabina's told us that she thinks that we need to stream education into primary or acute care. I can hear the mental health nurses. And
I have no problem with
and I can hear the aged care nurses.
Go for it.
Because arguably the burning platform or the burning ambition in aged care is as potent as it is in primary care.
And I would stream them as well.
So do we need
Why
to
not?
completely rethink the education of nurses in order to equip them for the future? Do we need to make major change to the professional regulation system to equip nurses into the future? And if so, how?
I think throwing everything up in the air is a really good idea. And I think that when you look at the current versions of the practice standards, they're very conservative, they're nice, and I think nurses do themselves a disservice by being nice. And we need to actually look at nurses as being science-based, evidence-based health professionals, and that, you know, we are targeting the future. And the wants of people of my generation as a nurse are completely different to the young people here today. You know, they have different wants and different needs and different expectations of what they want from the profession. And then we have a consumer that is changing their needs, and everyone knows Dr. Google, well, there's Nurse Google as well. And so they have a preconceived idea of what they want and what they're expecting. And you have to deal with that too. So we need to actually make sure that we're training nurses to do that. And as Sabina said, to actually look at how we stream nurses, we still get a lot of nurses coming out going, oh no, I need a new grad program in a hospital. And there's not, you know, there's limits to the number of new grad positions in hospitals. And then I was helping a niece recently who was a new grad and couldn't get into a program. And every employer that she was looking at wanted someone who had done a new grad program and had 2 years experience but couldn't get into a new grad program. And, you know, there are ways to do new grad support, transition to practice in primary care,
absolutely.
in aged care. We just need to make that more popular and to be able to have those experiences. There are a couple of people here that are involved in student placement programs. I know we are with ABNA and aged care, yeah. And the demand, we actually have a lot of students wanting to go to aged care, but actually trying to get them in is an issue into places. So we need to actually give them a much wider mix of what they're seeing. It's not just about hospitals. Machines that go ping are great, but, you know, at some point you actually need to have some other skills.
And aged care has a lot of machines.
Karrie, you had a comment.
Yeah, really, really good points there. What I wanted to take away, I'm a system thinker, and I know in the review it talked about the systems that don't interconnect and the silos. And as an industry, I think we've been living with that, and we've got tenants of houses of nursing, midwifery, etc. 20 years ago, working in a regional hospital, we had an interprofessional education unit, and I did supervise medical students. That was an interesting time. We've been trying to prosecute that interprofessional, either undergraduate training, common first year. We've tried to tackle this many times, and I think we need to have another crack at it. And I think supporting Sabina around remote, rural and regional is the playground to do that. Where you have resource constraints, some of those silos are reduced and the opportunity is greater by way of necessity. So I probably come back and think about, Sabina, what you said about nurse practitioners and how the genesis of that came from remote and rural, but we've not been able to land there. So I think that's a great opportunity. Recently, we've been talking about this issue of transition. So I think we need to lift it up to the principles of how can the professions transition. And I think that really supports the skills and capability matrix. What do we need for what population, where, and who has the skills and capabilities to do that? And in gender in our professions, the ability to transition. Why can't you go from have a job and in fact working in rural? A number of my colleagues worked in a practice for 2 days a week and worked in the maternity service, in the service as well. We need to be able to enable transitions. We need to create a way that when you graduate, even if it's postgraduate, that you have the skills and knowledge, and so do your supervisors, to enable you to transition. In Victoria, as a maternal and child health nurse, you need to be a registered nurse, a registered midwife, and have a postgraduate in child and family health. And we have clinicians there saying, and can you give me a graduate program there? There's something wrong if we have in the old world, a triple certificate, highly trained, science-based clinician that needs assistance in transition, and that's probably around the profession. It's not about the clinical aspects, but what's going on in our systems that we need that, and how do we enable ourselves to be able to provide that and be strong in that space. Thanks.
Sabina?
Yeah, I think it's we've got to do one really important thing here, and that is every graduate each year needs to be employed. And so they're either in a graduate program in acute care, aged care or primary care, in the big sectors, and in government, non-government, which means that there is a place for the feds to invest in supporting graduate programs and graduate activity in primary care, aged care, and so states to the hospital care. And if we make sure that we gainfully employ all new graduates, we've got a chance of keeping those who've finished and exposing them to areas of practice. We've got a large potential workforce in aged care who some of them are slowly ticking their personal care assistants or whatever, ticking their way through nursing programs, but we don't give them much of a hand, and we could actually have a systemic approach to that. Most of what you do in aged care, you do in the acute care sector. So I think it's really important that we use what we've got in front of us, and that we make access to nursing careers, health careers possible. We are in our University Department of Rural Health in this tiny little town of Emerald. We've just started a nursing program, 7 students, got 9 enrolled. Thank you, a round of applause. We have interprofessional allied health student-led clinics providing services to people who otherwise don't get access, supervised by our clinicians. But you could do that anywhere, and nursing is part of this. So we are looking to do things differently, but have rich experiences embedded in primary care. We're in the general practice, we've elbowed our way in, so we want to try and drive change from within, but within primary care. And so if we could have a way of exposing nursing for longer in undergraduate, when they graduate, they get much more comfortable and confident around the work and the challenge of the work and the satisfaction of the work, and see a career for them in the future. Instead, what we've got at the moment is we've got an emerging profession of travel nurses in Australia, so touring and getting paid. People really enjoy moving around, and in fact, not with the skills required to work in remote, not staying long enough to develop relationships and understand their client load, not being able to contribute 100% to the role that they're doing, yet filling a position for the time they're there. Now, there are a small number of these people who are highly qualified, but on average, Not at all. Neonatal intensive care refugees, aged care refugees, emergency nurses, great in an emergency, which, you know, will happen a couple of times a week, but the rest of the work, cognitively challenging, really complex work, you really need to have those primary care skills to be able to work through it. And we are contributing to poor health outcomes because our workforce is ill prepared. And so we have to say, we don't value this. We value, if we had an NP training program in primary care in remote and rural, for example, you could only get into that training program if you were a permanent employee of the service or the region. We change the dynamic enormously because you can't do NP training if you're not experienced in that area. So you need to commit to it. Doesn't mean people live and work in those areas all the time forever and ever, but we can change the dynamic and reward and grow the practice. So we want to give people the opportunity to see their career pipeline from being a high school student right through to being a manager of a service or being an MP or being a CNT, whatever they aspire to be, but make that possible.
Some of that's about the return on the investment that we've made in those people, isn't it? And that leads to retention. So, what's a reasonable time for retention?
And we don't need to worry about that one place. People tend to circulate, so they move between that area of practice because they enjoy the practice. They might want to try different areas or, you know, try different employment organisations to work for that might align with their values. And so it's a net gain for rural and remote and underserved populations, and it may be a loss for one area that's not engaging with their staff particularly well. But generally, it's a net gain, and so we don't have to stop counting, you know, you've got to stay 5 years to be of value. You know, people end up working in these sorts of areas, the context of that practice, for many years. And they bring with them that wealth of experience and knowledge and understanding and can get up to speed pretty quickly. But we don't reward that. We're not investing in. In fact, now what we're doing is undermining it. Yeah.
Comments from the panel? It strikes me that one of the drivers for these nurses is money.
Money's one thing.
And we've had a lot of conversation. We've touched on funding. We've touched on funding models, haven't we? We've talked about them. Stephen, I'd be really interested because you talked about the need for change in parallel in other aspects of the system, not just in primary care. So I'm a little bit interested in what you see being the change that needs to happen in other parts of the system, not in primary care. But I'm also really interested to just explore this funding a bit more because we've talked about blended funding. Mark talked about the 90-10 and the 60-40. How are we going to move from 90-10 to 60-40? What's it actually going to look like, taking into account Stephen's comment about this terrible fear of change?
So if I start off, the GP Incentives Review said, amongst other things, we need to put more money into primary care. So when we're talking about 90-10 to 60-40, we're talking about also at the same time growing the primary care pie. So you might still have exactly the same level of fee-for-service, I don't think we will, but on top of that there'll be more payments to the practice. And so at the moment, there is no payment for looking after someone between a visit, for example, to a general practitioner. We want to have a system where there is a payment to the practice to look after all of the patients registered with that practice. Yeah. And so you're going to have to make a payment which, let us say, is weighted towards whether they're older or younger or First Nations or not First Nations, called or low income. And the practice gets a payment which is to employ a multidisciplinary team. Yep. So at the moment, the main flow of the practice money is to reward the general medical practitioner plus moderate support staff, such as the person at the front desk. What we want to do is say, funding a single discipline in the naive view that they can do everything is not where we want to be. We want to be funding a practice which is able to look after the whole person. And it might have, in addition to a general medical practitioner, it might have a number of nurse specialists of some kind, it might have a podiatrist, it might have a psychologist. But that won't happen unless we have a funding stream. We've also said, gently and quietly, that such a practice could be a general nurse practitioner running the practice rather than a general medical practitioner. It is already the case that anyone in the country can own a general practice and employ or have contract arrangements with general medical practitioners. So, as I said, I moved practice because some Singapore venture capitalists owned the practice that I was going to. So, you know, we've got to get over some of the way we think about the way services were very well delivered in the 1950s. But in the 1950s, there are a whole lot of people who didn't get care, a whole lot of services that weren't provided, and we were a very different population. So what I've articulated is a direction for funding reform, the details of which have to be worked out, and they won't happen overnight. That is, you won't wake up on the 1st of July 2026 and say, whoops, we've got a total new funding. You'll start with a small change, and then they might say, well, why on earth do we have a separate payment for chronic disease management plans? Why do we have a fee-for-service plan? Why isn't that just part of what the practice does? And so we will have a shift. Some of the fee-for-service money might go and be replaced by more generic or practice funding. If you look at it, the government made an announcement a couple of weeks ago about increased bulk billing incentives. There were two components to it. The first component was a so-called tripling of the bulk billing incentive. The second component was an extra payment of 12.5% on top of what you otherwise would have got if 100% of your practice was bulk billing. In the fine print, it said, and your practice has registered for My Medicare. So it is a changed nature of how we're funding. No longer is, you know, open slather and so on, but we are setting the framework for a new type of practice. And nurse practitioner-led practices, of course, can also register for My Medicare. Does that answer the question? If not, why not?
Stephen, can I ask, how will you drive the behaviour to ensure that chronic disease plans and management occur? Because at the moment, even though they're incentivised with a payment, a great number of practices aren't doing them.
For the last 50 years or so, 30 years or so, the Commonwealth Department of Health has assumed, except while Mark was there and while I was there, the Commonwealth Department of Health has assumed that the entirety of policy is adding a new item to the Medicare benefit schedule. That's it. What we're now saying is that is not it. And just adding the idea of a chronic disease management plan or a mental health management plan, the idea that having a mental health management plan, which means you can see a psychologist, but you can't afford to see the psychologist, and the psychologist just generates more visits in a supply-induced demand way, is not good policy. And we have to throw it out and start again. And part of throwing it out and start again is saying, if we have My Medicare, people are going to register with that practice, which means we have a denominator against which we can measure the practice. To what extent do people from that practice end up in hospital with potentially preventable hospitalisations, for example? So we can start to measure the quality of general practice in a way we can't now. Did I get it right, Sabina?
It's quite a long time between, you know, having a chronic disease and not having it well managed to ending up in hospital.
6 months is the evidence.
6 months, okay. I would have thought it would be a bit longer, but
so some people claim that if you intervene 6 months in advance, you can stop.
I'm sure that's the case, but think that...
But you'd know better than I. I'm an
I
economist.
think that there's more likely a couple of years. But I still think you can... You've got PHNs and others that provide data back to practices so they can understand their patient load and what they're doing and all those sorts of things better, and I think that's important, and that level of support's really important. But I think being able to keep pace, well, I don't know what the future holds, but we will learn something soon, next week, next year, around what will improve people's outcomes if we do X, Y or Z. And it's how do we motivate the doing the X, Y and Z by whoever in the practice through the payment, because the money does tend to be the driver. How do we do that in a way, and I'm completely with you, I don't want to see any more item numbers, but I'd like to see some sort of activity list for which you have to be able to demonstrate you're doing, meeting KPIs or targets of 60, 70, 80% of whatever of your client load have completed cycles of care or whatever, so that we are actually guaranteeing we're offering appropriate care. Go for it, Karen.
Karen.
Look, I'm going to take Stephen's money, and I'm going to, which is great. And I've managed general practices, so I know a bit about how they work. I've got 100 diabetic patients. I know roughly how much it's going to cost for, a year of maintenance for them without acute things. And if I was to get a pool of funds that covered my 100 patients, that I could predict I'm going to get this much money, I can plan my staffing, I can plan to run nurse-led chronic disease clinics, I can work out how many team members I need, I can plan that in advance. Currently you can't. It's ad hoc. You come in, patients might come back for their follow-up, they might not. And so what we could then do, once we've got all of that happening, is we could actually look at mapping, how is this progressing? I saw this fantastic presentation by Bupa Health Group Aged Care, where they had introduced nurse practitioner-led clinics in their hard-to-service areas. And they actually had multidisciplinary referrals, they had telehealth coming in, and they were able to, they actually had mapped the improvement in wounds, the improvement in nutrition in patients because they could get access to dietetics really quickly, and actually improvement in mobility in people because they were getting up. So they're actually looking at outcomes, and we can move to that, and maybe one starry day, one starry night, we could actually move to some sort of outcome bonus payments, which is a bit, mostly they focus on targets at the moment, but if we actually did want to really get serious and look at outcomes, that would be, I think, really important. And the other thing we have to do is change the mindset. So we need to change the mindset of the people working in general practices, but we also have to change the mindset of consumers that they don't just need to see the doctor. There are a whole pile of other people that can help. We need to change the mindset of practice managers who are married to fee-for-service because that's all they know. Most of the younger GPs, that's all they know too. So we actually need to change the mindset, and dare I say a number of nurses as well. So change the mindset around that, and is part of our change management process.
The change management process, which as Stephen has told us, is going to be extremely difficult because everyone's terrified. Because everyone likes the status quo because it's comfortable and it feels really safe, and the future looks scary indeed.
I think that's where Mark's capability framework comes in, and mapping the disciplines and who can do what and what the overlaps are. It'll change. To me, that will be a real game changer for the way that care will flow.
But that's one of the reasons why in the incentives review we emphasised the pot was increasing. We are not taking money away from you. You're not going to lose your mortgage, or more likely your Lamborghini. What we are saying is there's a surety here that this is a growing pie. The population is ageing. The population is getting sicker. So there's going to be more work for everyone. It is not a zero-sum game.
Yes, plenty of work to go around.
Plenty of work to go around.
No need to be frightened. Absolutely.
And we've got the early adopters. There's enough early adopters who would go to demonstrate. So I don't think it would take as long. I'm not as negative.
Yeah, so I'm older than you, Sabina, and I've now got used to the idea that not everything has to happen tomorrow.
Yeah.
Start it.
Well, Mark's already told us it's a long game we're playing.
But Sabina well knows, when we were on the National Health and Hospital Reform Commission, what we
2008.
talked about was the grit in the oyster. You put the sand in the oyster and it grows a pearl, but it doesn't grow it overnight. As long as you've got the sand there, things will change.
Mark?
Yeah, look, really fascinating conversation, and I mean, I think it is about, I agree totally with Stephen about you've got to actually make a start, right? So, and defining that start is really important. It's probably not good to do that just before an election. It's probably better to do it. It's probably better to do it, you know, when
Just after?
when the dust is settled. But essentially, this notion of a 60-40 move from 90-10 is agreed, right? So there aren't really any...
Agreed by everybody?
It is largely
It
agreed.
was in the 10-year plan produced
Correct.
by
By
Minister
Greg
Hunt in the budget, the last budget of the previous government. So it is a Liberal policy, is the way I'm phrasing it. I don't think they believe that, but, you know, that's my line and I'm sticking to it.
Yeah, so this fear that somehow everybody's going to rise up in anger, there's not a lot of evidence for that.
Well, there will be shroud waving, but...
Yeah, but
it's
I guess the
background
question
noise,
is that the AMA and the College of General Practitioners agree with the move towards that position.
That position.
Right, so that's on the public record.
Wow.
So hiding
need to
in plain
remind them.
sight, you could see. So the question is really, there's a timing issue, and these sorts of changes, you need a catalyst to do that. And it's essentially after an election is a better time to do it. So we then, if you sort of, you get them together, and which includes all of the health professional groups, because they all stand to be impacted, influenced, supported or enabled by this. So you start with that kind of, you know, grand bargain kind of approach. You then move towards a series of design principles. Stephen rattled through them very elegantly at the beginning of his discussion, but, you know, it's essentially, it's for patients must be registered with My Medicare, and we kind of all agreed on that. Okay, so that's a good start. Second point, I'm just reading from my report, by the way. The health professionals eligible to participate in that scheme must be part of a multidisciplinary team. Okay, so but we've just got to get people to agree to that. Digital infrastructure is mandated as part of that, so that the benefits that we will eventually get from this massive investment over a long period of time into digital infrastructure, My Health Record, etc., and of course it will come. If you're not in that world, you're not in the blended payment sort of system, right? And that you then start to develop some criteria. That is, that people must be able to get affordable, your patients must be able to get affordable access to a prescribed range of services. So you've got those kind of overarching principles. You then move into the how do you make the money, how do you distribute the money equitably to the areas and the populations that need it the most. And essentially the essence there is you start to develop an appropriate risk stratification of populations. And those risk stratifications...
And that's available.
Yeah, of course.
That's available. We recommended we do that on GP catchments, that all the data's there. And now, in fact, we can do planning almost in real time, well, certainly in 3 months' chunks. It's remarkable. Before you'd have to wait for 5 years for a report to be published, but
that's right.
Now it's real time.
And even the tool that was developed as part of healthcare homes, you know, I mean, it provides a starting point. So there's a bit of rocket science involved in risk stratification, but if it's essentially some kind of linking of the risk of the individual aggregated into practice populations and then translated into likely healthcare needs and cost associated with that, then you've got a model that you can apply anywhere. So you kind of progress.
And you build a teaching training.
That's right. And Stephen's point about this not being, just reallocating existing money. Of course, that has to be part of it. But about this being accompanied by a transitional or growth arrangement that may span over a 4 to 5 year period that enables you to transition your business model from what it has been for the last 20 or 30 years into the desired business model. So there's support, financial support for that. And then you start to identify areas of obvious disadvantage that are only going to be winners out of this and will be quick winners, and they would be areas particularly of significant socioeconomic disadvantage and regional and rural areas, and you kind of build the kind of transition on that. But you've got to have a governance mechanism that oversees all that.
Yes.
And the governance mechanism, you know, at the end of the day, will be largely the federal government, because this is largely federal government funds, but it will have an interface with the payments that are made to the states through the National Health Reform Agreement, the extent to which they impact on services provided for primary care-like nature by state government entities in rural and remote areas or other parts. So, I mean, I think it's really, you know, I believe the elements are in place. This is highly complex work. It's not something to be rushed. And probably one of the downsides with the NDIS was, you know, maybe with the benefit of hindsight, a service model that at its heart and its policy intent is really good, maybe a bit more effort on some of the kind of market impacts of that. Yeah. So, you know, I think the elements are there. Critically for the College of Nursing and your, you know, desire to advocate strongly in this space, you've got to have fellow travellers. You've got to have an advocacy coalition. You've got to have people from the consumer movement, the other professional groups who've basically all said they quite like this. And, you know, so what you're presenting as a dialogue to the community and what you're presenting as a case to the government is one that is shared by all the people that matter. And you're kind of isolating obvious resistance much more effectively. That makes decision making by government easier. It doesn't always make it possible, but it does make it easier than if that consensus is lacking, the design is poor, and the evidence is lacking. And in fact, you know, none of those are problems that can't be solved.
I think the importance there that can't be overstated is the necessity for a coalition of all the people who are going to be affected. I remember when we were lobbying to get ANMC appointed as the accrediting authority for nursing and midwifery, the message was very clear from ministers. If every nursing organisation agrees on this, then yes. But if they don't all agree, then no. So it's the same here. All those affected, the multidisciplinary team and the consumers and the practice managers and everyone, if they all are in agreement and lobby, then...
And don't underestimate the power of the consumers.
Absolutely.
I think the power of the consumers is extremely important. Mark spoke about the power of the consumers, and certainly in the work we did on the National Nursing Workforce Strategy, some of the best feedback we got was from consumers. It was quite amazing. The clarity with which they could identify problems and solutions in their own areas was really useful. I think that possibly you're ready to ask questions of the panel, are you? Yes, Jane's nodding vigorously. So what I'd like you to do, the roving mic is going to come round. There's probably going to be a mic at each end of the room. You'll need to put your hand up to get the mic.
There's one over there.
And then what I'd like you to do is just identify yourself, please, before you ask your question.
Okay, I'm John Brown from Queensland. I'm meant to be retired, but I'm still working 2 days a week in general practice and still learning a lot. I want to make a positive statement first. Nurses had the power to bring about change, and we've proved that. 2 years ago, I asked the Federal Secretary of Health, why is it that nurse practitioners in rural and remote areas can't do health assessments and care planning? That came into effect October, November last year. So we did make change. I also want to go back a bit to say, what is the root cause of our health system? Why is the health system in crisis? Yes, it's workforce, but really it's about politicians knowing that they've got a 4-year term. What can I do within that 4-year term to get the votes? Oh, let's put some more bricks and mortar in. Let's put some more beds in. That doesn't address the issue. I'm impressed that Stephen talked about chronic disease. We don't do enough on chronic disease. And I was impressed that Sonia this morning spoke about social determinants of health. I just want to raise the issue about community development principles, that you're empowering communities to address the health issues. I am concerned about, at the moment, about the erosion of the registered nurse role in general practice. The PHNs are actually training receptionists to do wound care, take ECGs, those sorts of things. And because it's cheaper. And we can employ an enrolled nurse and we'll get them to do the health assessments. That's what's happening in the real world. And Stephen, you referred to the chronic disease care plans at the moment. What I'm hearing is that a GP management plan will be there, but maybe the team care arrangement money will disappear. So that's something, and there is an erosion. It's not about let's add another number. There's an erosion of the existing billing numbers. A typical example is that for a GP to read an ECG, 4 or 5 years ago, they got $40. They get $12 now because they're not meant to interpret the ECG reading. I'm not promoting the GPs, but simply saying the billings have changed.
I'll do it now.
I do a lot of diabetic care plans, and I had 400 patients I was looking after, and I could say to the GPs, 7% of our population are non-compliant. The rest, we've got them on track. And it's simply about the registered nurse doing health coaching and being prepared to do that sort of work. I've got a degree in health promotion as well, and I use that a lot, as well as health coaching. So when we talk about getting nurses ready to go into the workforce in primary health care, that's the sort of stuff they need to be learning.
Yeah, that's a very important point.
Yeah.
Yeah.
So I've got quite a few things here, but I won't go into.
Okay,
Thanks.
all right, well, thank you very much for that. Now we'll go to this side of the room. Could you hold the microphone a bit high?
Not on, Louise.
Turn it on.
Hi, I'm Louise Whiteman and I'm a registered nurse, registered midwife and child and family health nurse, and Sabina's work really resonated with me because most of my working life is regional, rural and remote. And my question is, how do we take the best of the old ways, as I was hospital trained in those days, and going through university to get that evidence-based knowledge, how can we bring the two together? Because as a hospital trained nurse, I could hit the ground running, but as looking after students, undergrad students that I've done, they just don't get enough practical time, and that's why they're so nervous. That's why they're desperate for a grad program, because they don't feel confident. So I'd like to see the merging of those. And, you know, I loved my time at Bush, delivering a baby one day, A&E the next day, and I really think we should sell rural and remote because it's a great place to work.
I'm not sure what the question was.
So I think we want to be really careful. We're not suggesting that we don't have a university program. That standard's set, and we absolutely keep that. What we want to do is bring in the best of what we know around exposure and immersion in practice, and in this case primary care, for as long as possible as a student, so when they graduate they have got some confidence and competence, they've got their confidence in that in that context so that they can keep on going. And so by having a change in the way the curriculum is looked, we could, maybe if we're introducing more primary care placements, maybe we could even expand the clinical placement hours. I don't know. Some of my university nursing colleagues will want to throttle me for this. But there's a balance here in how we can get placements for students sufficiently across Australia in order to be able to graduate them. I think we're not using everything that's available to us at the moment, but you've heard me say, I really do think that we can change the way we, particularly in third year, but even before, where we integrate students across the year in practice so that when they graduate, they don't need a big grad year. They need support to transition to a graduate, but they have got so much more experience in primary care. And in the teaching, training and research system, we could do that.
And then they'll stay, because they know.
They'll stay in that sort of practice, that's right.
12 months and they're out here because it's been dreadful.
Yeah, thank you.
Thank you for that question. I'd just like to point out that the 800 hours is the floor, not the ceiling.
That's right.
Jane.
Thanks very much. A couple of responses. Just to that point that you made a minute ago, it's about the quality
Jane,
of
who are you?
Oh, sorry. I'm Jane Mills. I'm the Dean of the La Trobe Rural Health School, which is a large multidisciplinary school down in Victoria. We have about 800 nurses, and I'm a nurse, proud nurse and a fellow. It's about the quality of the placement rather than the number of hours, so I think we need to stay focused on that as well. The idea of just increasing the number of hours is not necessarily going to make a more confident graduate. I had a question for Sabina, but just before I get to the question to Sabina, the other thing I'd like to also suggest that we put on the table as something to consider is employment-based pathways. So finding a way, creating connections between students and particular organisations. So how do we actually build a relationship between a student and an organisation whereby they actually feel really well supported through their clinical placements, maybe a lot of them at one partner organisation, mentoring, and then potentially a grad job at the end. We've got a pre-budget submission into the Victorian Government at the moment for this as well, so we've done a lot of work on this and worked hard with our rural partners to develop up a model. So happy to share that with anybody that's interested. So my question for Sabina is, Sabina, are you suggesting that we need to actually change our registration structure to mirror something like the United Kingdom, where undergraduate Bachelor of Nursing degrees are in fact specialist qualifications?
No.
Okay, good.
So no, I'm not. In that, I think your undergraduate qualification is your undergraduate qualification. But so if you do your your nursing placements primarily in Royal Prince Alfred Hospital or whatever, and you're in the medical ward, the surgical ward, you've had that exposure. Primarily, that's it. That hasn't provided you any grounding for aged care, mental health, primary care, but you're still a registered nurse. So I think we can stream acute care, and I put aged care and acute care in that that you can stream people in aged care where they can move between acute care and aged care, but primary care is quite different, and there's an anxiety if we don't put students in the hospital, they're not getting proper training. And I think we can change that completely, and we should. We just need to look at the variety of experiences they're getting and what sort of primary care services that we're immersing them in for that. So no, I'm not suggesting that we have it specialised at all.
You wanted to go.
Yeah, no.
It has been noted, her distance on the limb. Thank you for the question, Jane. Fran.
Thanks. I'm Frances Rice and I work in the Commonwealth Department of Health and Aged Care. There are really great examples of multidisciplinary teams working in the Aboriginal community-controlled sector, but there's patches of it elsewhere. Do you think that the My Medicare person registration model will help that type of model be expanded into the rest of the primary care sector?
Yeah, I think we take the best of what we know in the community control sector and apply, but and also take what isn't happening in community control sector. So, for example, there's quite a latent uptake of NPs in community control because they don't get any benefit from an NP over a remote area nurse, and so they're not that interested in supporting NPs or NP candidates. That might change because from a financial perspective, no difference, and they're working in a developed system of care where people know what they can do and can't do in that service. So they could and should be able to do more around pushing people to the top of their scope and qualifying. But yes, you can. I mean, that's what Mark's recommended, we recommended, Steve's recommended in all of our reports, that these are the examples of where you bring people together, and they're great examples of where they adapt and adopt to the context of where they are. So what happens in Townsville is quite different to what happens in Mount Isa, different to what happens in Derby, which is different to Halls Creek, or Katherine as opposed to Largemanu. Like, they will blend and adapt because they have enough money to be able to employ people and not have to generate income. The way that they provide their comprehensive wraparound care is through what they generate through Medicare and their social care and other aspects of care. So Medicare is really important to these services, but their core services are funded, and that means that they're not overly reliant on one particular discipline. Now, it's not that they do it easy in recruitment, but it is easier for them to plan for what they want to do.
Mark?
The point I'd make is that, I mean, the stage we're up to now with My Medicare and registration is a big improvement on not having it. But I think it really should be seen as the foundational element of a broader system of population-focused risk-based payments, where there is a benefit to the patients because that money is aggregated into a practice, and a practice can, by amassing a significant number of people, build economies of scale and then start to utilise that money more flexibly. But enrolment or registration, I should say, by itself, it's just one mechanism. When you start to link it with greater uptake of digital tools and technology, when you start to provide a kind of a practice environment with accountability measures that specify what is broadly to be achieved and not be overly specific, but specific enough so that it's not just slush money, then that's when it starts to take effect. And I think the point we've made in this discussion is it's the beginning and an important marker on a journey, not a magic bullet in itself, but it's a good starting point. And it starts to make providers and practices more broadly responsible for the patients that they enrol and or register, and the significantly larger flexible payments that go to them. So I think that's the way I look at it.
It has been shown that it can be done.
Absolutely.
Hi, my name's Caitlin Moore. I'm a fourth year registered nurse working in New South Wales, and I am the new chair of the ACN Next Generation faculty. So to first of all acknowledge, great panel. I feel like there's been a lot of insights into where we are at currently and where we want to head to in terms of optimising the role of nursing in health reform. In terms of that, I do acknowledge as well how you've mentioned that this is a change that won't happen overnight. It's not, we'll wake up tomorrow and, at a blink of an eye and things change. It does take time. So in that, as someone who is an early career nurse and is a part of the next generation of nurses and advocating for those next generation of nurses, I wanted to put to the panel, how would you say that beyond, obviously, things outside of our control, if it's state-led, if it's nationally-led policy reform and change, how do you see next generation nurses as being able to advocate for and promote and implement these changes to actually make meaningful change and, I guess, enact this policy reform?
I'm going to ask Karrie, who's a leader among nursing.
Thanks. Thank you. I think that comes back to the ease that I talked about, really. And actually, I had prepared, this is because I'm dyslexic and I have to chunk information together, is that there are a number of C's as well. And it's about connectivity, it's about communication. I have to go back to my notes to see what were the other C's that I wanted to talk about. But I think that education, being empowered, being connected, the advocacy, I think this is really a big piece for us as a profession to get strategic and to understand how government and policy direction works, get strategic, have opportunities to watch this and be involved. I think that's, you know, pivotally important. And, you know, I could probably call myself a novice chief nurse and midwifery officer as well. And in my process of transition and learning, I think it's get curious, get interested, ask the questions, speak up, contribute would be the key things. I think know it's part of your role. I think that's the takeaway. It's if not me, then who? And it has to be us. I'm doing a lot of work at the moment in Victoria around our maternity services, and I think as professions, we have great passion. Use that passion to be strategic. So use it as an energy space, but not as a label up front, and get strategic around what are the pivotally important things that we need to be working on. Have a radar, ask questions, get involved, advocate. Being involved in professional industrial organisations are really great. I'd probably take away, in the National Nursing Workforce Strategy, we did have an adage, how can we get in the tea room? And so I think these tea rooms are fabulous cacophonies of all sorts of things for us to generate really intelligent, strategic discussions, to have nurses and midwives understand the complexity of Australia's healthcare system and how it's funded is important. We know that knowledge and data is power, and so we need to be empowered to understand that, and that's from all the way along. You need to understand our political system and cadence, and I would say that needs to go back into high school as well. I was fortunate to live in a part of Victoria where we have an independent member who happens to be a nurse and midwife researcher, and you know, kids at that time were exposed to grassroots understanding of how our government works. We need to do that as a profession to understand how that works. That's what part of today is, and I see that you know, progressing as a nurse or a midwife in your leadership, we need to build that element in there as well. So I hope that answered your question.
You can buy Professor Duckett's textbook, Australia's Healthcare System.
Some of us had to study it when we were doing our degrees.
But can I just add to that, get involved with the consumers. So consumer organisations wherever you live. So whether it's Health Consumers Australia, whether it's the CWA, whether it's the whatever the Migrant Resource Centre, whatever the consumer group is of where you live and work, and your peers live and work of your network, your community of interest, and the emerging nurse leaders, the next generation, make it central to what you do, so that we have to listen as well as speak. We've got to hear from people as well as inform, and I think that's really important.
Can I just add one last thing? I was just thinking about, because it was about connection, and I think about the skills and capability matrix. I like to visualise the workforce as a Venn diagram. And if we have a Venn diagram, then there's no gaps in between. Nobody falls in between the gaps. to do that, you need to develop good relationships. So I think it's around professional bodies working together, as we see with Nursing Peaks, but even more broader than that. And, you know, my previous roles had me involved in Institute of Digital Health and elements where there's multi-professional groups as well. That builds great cadence, great learning, different advocacy, different skills. So, you know, all the benefits we all get from working in multidisciplinary teams is you see, you know, how another clinician can get action based on how they're trained and how they present information. I think that's the same for, you know, advocacy and professional organisations as well.
Yeah, totally.
Hello, Naomi Dobroff. I'm the Chief Nursing Midwifery Information Officer at Monash Health and also chair the Chief Nursing Information Officer faculty for the college. The discussion has been extraordinary today, and I suppose I want to add some of the conversations we've been having in our faculty, and they've been around, obviously, optimising the role of nursing and health is really going to include digital health and is already including digital health. And I heard Sabina talk about, you know, AI scribes and the influence they're going to have on the work we're doing in primary care, but also more broadly. And so I suppose I just want to bring into the room that we're doing this work that's going to take time, but at the same time we've got technology coming in on the side and influencing all the ways that we're providing care. A lot of those technology companies are US-based. They don't understand our models of care. They don't understand the way that nurses work in Australia and could work better in Australia. And so I just want to put into the room that there's a real tension, I think, in taking time when also we've got a lot of technologies that are coming up and being, you know, really advancing very quickly, and other health practitioners and other health professions are grabbing those technologies and running with them, not always safely. But, you know, I suppose how do we stay abreast of that while we're doing this slow process of changing the way that the care structure, particularly in primary care, is seen. So I just, yeah, something that we've been talking about.
So, thank you, Naomi. I think it's important that we think about change. There's the very, very good Canadian health policy author who talked about the scale and pace of change as a 2-by-2 table in a sense. You can have small scale incremental change, you can have big change, huge system change, but you can also have the pace can be slow or fast. Big bang change, for example, is fast. And Carolyn Toohey, her name is, and she talked about each of those 4 cells, and the cell that I quite like, as you could understand, is large scale but slow pace. And if you're on about that, she calls it, I think, mosaic, or anyway, but you set a blueprint for where you want to go to, and you proceed incrementally towards that. That doesn't mean you sit back on your hands and just wait for change to happen around you. And it's interesting to look at Mark Butler as Minister for Health. When he was appointed Minister for Health, I think he assumed he was going to have 2 terms, at least. And I think what he did was say, I think I've got 2 terms. I'm going to try and do fundamental change over a 6-year period. He appointed Mark to do the scope of practice. It took Mark 18 months or whatever it was to get all that, and then it's going to be implemented in the next term. So he didn't say, I'm only going to do things that can be done in the first 3 years. He had a longer scale. So the point of that is that change is, you're quite right, change is happening all the time and happening very fast in that technology world and in certain other worlds as well. So what we've got to be doing is the system change and the technology change and so on have to be going in parallel. The trouble is some of our changes require legislation and blah and blah and blah, and that takes a while. Some of them just happen overnight, like the scribes, for example. And they just flow in and regardless of the risks and get implemented. So we've got to be managing all of this. So I think the issue is what can be done now, bypassing all of these things, and what do we have to wait, and be really strategic about where we invest our time. Can I come back to Caitlin's comment earlier? I think one of the issues is, and I think you said being at the morning tea table or whatever, but being involved. Now, I don't want to put a burden on all young people to spend all their time going to meetings, as enjoyable as meetings are. But what I want to say is you've got to put yourself up to be part of these advisory processes and so on. So I chair the board of a PHN, and we've got what used to be called the Clinical Council or something or other. We changed the name for a whole host of reasons, but it's now called the Clinical and Practice Council, which is multidisciplinary. And so there is a place for nurses there. In our board, we've said we are a strong board, and so we can afford to have people coming onto our board who aren't as experienced as in other places, because we see ourselves as a place to build experience and so on. So it's thinking about all of those sorts of opportunities to actually have the voice of nurses at the table, in the same way that for decades you couldn't have a health policy meeting without a Noah's Ark of doctors, 2 physicians, 2 surgeons, 2 this, 2 that.
Yeah.
So, you've got to actually think about nurses need to be in the same position, that you can't have a discussion about mental health care without mental health nurses there, not just psychiatrists and psychologists and consumers.
And not just because we're loud, but because you actually make a difference.
Well, there's things you do that the others don't.
That's right.
So if you want the whole picture, you need the whole team.
Yeah, exactly.
I think that is a very fitting point on which we're going to end our conversation. You are not surprised, I know, to understand that we've gone over time. And we could continue to happily go over time for quite some time now. However, lunch awaits us. So could you please join me in thanking our panel for giving so generously of their expertise here today. Aaron, Stephen, Karrie, Sabina and Mark.